You can just click on.
Start video.
Sure.
Hi, this is Julie Miller with Virginia Cardiovascular Specialists. Thank you so much for joining us today for valvular heart disease, what you need to know. We have two great presenters today, Dr. Chung and Dr. Posenau. Both are structural heart physicians with VCS. Today we will be muting the presentation, so if you do have any questions, please use the chat functionality at the bottom of your screen. It's called chat, and type in your question and we'll do our best to answer them at the end. So without further ado, I'm going to hand it over to Dr. Chung. Thank you.
All right, thanks, Julie. Hopefully you all can see me okay. I can't really see a picture of myself, so hopefully I'm sitting in front of the camera there okay. So again, my name is Matthew Chung, and my colleague here, Dr. Trevor Posenau, will be kind of doing the second half of the presentation. But we just want to take some time to talk with you guys today about valvular heart disease. You know, what is this and what kind of things do you need to know about it? So try to advance our slides here. So just to let you guys know a little bit about ourselves, as you'll see kind of going through this slide, Trevor, or Dr. Posenau and myself have known each other for some time. We both did our medical school at the University of Virginia, and then we were both at Duke University for, there we go, that's a little better, for internal medicine training. And then we went off to Washington University in St. Louis for cardiology and interventional cardiology training. And the 1 year out of our 8 postgraduate years we had apart was actually for our structural heart disease training. Trevor stayed on at Washington University in St. Louis, and then I went back to Duke University to do my structural heart training. So it's been great working with Dr. Posenau. He's a good friend and colleague. We've worked together, and I think it's great that VCS was able to bring both of us on to help bolster our already very strong structural heart program. And I think in the almost year now we've been here, we've seen some really exciting things for our program. It's really grown, and we're looking forward to seeing where this program is going to head in the future. So before we get into the specifics of aortic valve disease and mitral valve disease, let's talk a little bit about the heart. So this slide here shows you the heart, and it shows the heart's 4 valves. There's a number of arteries that come out of the heart, and just to kind of show how the circulation works, does my arrow show up on the screen there? Yep.
Yep.
Okay, great. So if you look here, this right here is actually the right side of the heart on the left side of your screen. And this is where all the venous blood from your body returns from your legs and your arms, and all the venous blood returns to the right side of the heart right here. That blood then has to pass through this valve here, which is the tricuspid valve, and that goes into the right ventricle. And this is where the venous or the blue deoxygenated blood returns. Then the right ventricle pumps the blood out through this valve here, the pulmonic valve, and that goes out into the pulmonary arteries, these blue structures right here, that feed into the lungs. So then the lungs, they oxygenate the blood, and then that blood returns by way of the pulmonary veins, which you don't see in this picture, but it comes back to this structure right here, which is the left atrium. From the left atrium, the blood travels through this valve, which is called the mitral valve. You see it depicted here. And then it goes into the left ventricle. And the left ventricle is the main pumping chamber of the heart. And this is what ejects the arterial blood, or red oxygenated blood, out of the aorta that feeds it to the rest of your body. And the valve that regulates the blood flow out of the left ventricle is this valve right here. And this is the aortic valve, which is depicted here. And so this aortic valve regulates the blood flow out of the aorta, which then goes to the brain. Then the aorta comes down and comes to both of your legs. And so that's kind of how the body's circulation works. And so the heart valves are very much like any other valves in any other kind of structure, whether it be an engine or in some kind of piping system. You know, some valves are meant to be two-way, but the valves in the heart, they're meant to be one-way valves, which means that blood should go through the valve, then the valve should shut, and the blood shouldn't leak back through the valve. So that's how all of these 4 valves in the heart were made. They should allow blood to go through them, but shouldn't let it leak back the other way. And also, they should open freely. and let the blood freely flow through the valve without any kind of obstruction or hindrance. So that kind of lays the background for what we're going to talk about today. Today, we really want specifically focus on two of these valves. We're going to talk about the mitral valve and what kind of problems you might develop with your mitral valve and what we can do about that. And then we're going to talk about the aortic valve, and it's the same way, what kind of issues you can develop with that and what we have to treat that in our current time. So here at VCS, we have a very rich experience with valvular heart disease procedures. We were actually the first program in the greater Richmond area to do transcatheter aortic valve replacement, or TAVR. And since we did that several years back, we've just grown the program. We've been able to bring in people like myself and Dr. Posenau to help grow the program and keep taking it further. We've been an early adopter of the technologies we now have to treat mitral valve disease. And again, I'm just really excited to see how much more we can grow this treatment program that we have to be able to provide these minimally invasive catheter-based treatments for our patients, so that they can recover more quickly and not have to go through open heart surgery. So today, again, we're going to focus on two of these procedures. We're going to talk about the aortic valve, and specifically transcatheter aortic valve replacement, or TAVR. And then we're going to talk about the mitral valve. And we're going to discuss transcatheter mitral valve repair, or MitraClip, which is the only device right now that's commercially approved to treat a leaky mitral valve. So first, let's talk about transcatheter aortic valve replacement, or TAVR. So just in way of background, we use this mainly to treat aortic stenosis. Sometimes it can be used to treat a leaky aortic valve or aortic regurgitation, but predominantly the technology is used to treat a narrowed or stenotic aortic valve. So when we say aortic stenosis, what that means is that main valve that we discussed on the other slide that regulates the blood flow out of the heart into the rest of the body, that valve can become narrowed or stenotic. And so that process is called aortic stenosis. So if you look in this slide, you'll see that here, this is mild aortic stenosis. The leaflets, when we're first born, there's 3 of them in most people. They're nice and thin, they're pliable, they open freely without any kind of obstruction. But what I like to tell people is, if you can imagine a door, and you open and close that door hundreds of thousands of millions of billions of times, over time, that door might build up a little bit of rust on it, and it may not be so easy to open that door. Well, the aortic valve is very similar to that. It doesn't rust, but the aortic valve can develop calcium, much like a door might develop rust, which hinders the door from opening freely. And so that's what's depicted in these pictures. You see in this picture here, there's a small amount of thickening, a little bit of calcification. As the disease progresses, this becomes more moderate. You can see the leaflets are more calcified and thickened. And finally, as this goes on with more wear and tear, with the heart valve opening and closing with each heartbeat, this eventually can become severe, where the leaflets become severely thickened and calcified. And so what happens is, just like an old rusty door may require you to push really hard to try to open it, and it takes a lot of effort, in the same way, this valve, as it becomes more and more narrow, the heart has to work harder and harder to try to eject the blood out of the heart through that restricted valve. And this puts a lot of workload on the heart. If I handed you a dumbbell and said, here, curl this and don't stop until I tell you, you could probably do it for a while, but what if I added another weight on there, and I added another weight, and I keep adding weight, and I say, keep going. Eventually you'll get tired and you won't be able to do that curl anymore, and you'll tire out. And the heart's exactly the same way. As this valve narrows, it's putting more and more stress on the heart, and eventually the heart says, all right, I give up, I can't do it anymore. And when that happens, people start to develop symptoms. So what are these symptoms that people can develop? Well, there's a couple of them. Probably most commonly, people experience fatigue as they're trying to do things, go for a walk, even just doing simple tasks around the house, like making the bed or vacuuming the carpets. They may feel fatigued. That far and away is the most common symptom that people experience. Probably the second most common symptom would be shortness of breath. Again, when you're trying to do things, this becomes progressive to the point where people may feel short of breath just getting out of bed and trying to walk across the room. Another symptom people can develop is what we call angina. And that's just a term that we use to describe chest discomfort that's related to the heart. And this is because, as I described previously, the narrowed aortic valve puts an ever-increasing workload on the heart. And at some point, the demand is so great on the heart that the body can't supply enough oxygen to the heart muscle to support that increased demand. And this can produce chest discomfort, or something we call angina. As this disease progresses, people can actually start to feel lightheaded. That's something we call presyncope, or they can even pass out, something we call syncope. The reason this happens is because as that valve becomes more and more narrowed and it's harder for the blood to come out, the blood pressure to the brain is actually too low. And so with the brain not getting enough oxygen and enough blood supply, people can actually pass out. This is something that, when it happens, really worries us a lot, because that means that the aortic stenosis has really progressed into some of the later stages. And when people start to tell me that they're getting lightheaded and passing out, that really tells me we got to act fast to get this evaluated and replace the valve. Another common symptom people may experience is swollen ankles and feet. And this is because the heart muscle, as it gets so tired of pushing against a narrowed valve, can start to weaken and not pump as effectively. And when it doesn't pump as effectively, blood can back up into the venous system, and it kind of leaks out into the soft tissues, into the legs. And these are symptoms of congestive heart failure or a weakened heart muscle. And so this is sometimes how people will present and tip us off that they might have a problem with their aortic valve. I just want to mention that, all of these symptoms very commonly by patients and by physicians can be misunderstood as, quote, normal signs of aging. But, I think that for people who have stayed active and they try to maintain a reasonable kind of functional status, it shouldn't be normal to develop these types of symptoms. And so if anyone's experiencing things like this, it's definitely worth mentioning to your doctor to have it further evaluated, because they may not just be normal signs of aging. These could be symptoms related to valve disease, maybe with the aortic valve, or potentially with the mitral valve, which Dr. Posenau will discuss later on in this webinar, as a lot of the symptoms overlap with mitral valve disease as well. We do know that once people have severe aortic stenosis and once they develop symptoms, it's kind of sobering. By 2 years, about 50% of people will not be with us anymore. And if you think about, some of the cancers that are out there, this is actually a worse prognosis than a lot of these cancers. And so we need to, take these things very seriously and be very vigilant to look out for these types of symptoms, because if it is related to significant aortic valve disease, this problem can result in a lot of morbidity and even death in a short period of time. So now that we've kind of discussed what aortic stenosis is and what symptoms to be on the lookout for, how do we treat this? Well, sometimes, people may try to use medical therapy. There's not really a whole lot we can do with medicines to try to reverse this process. Once it's there, it kind of is not going to be reversed. But the medicines that we might use would be really to treat the complications of the narrowed aortic valve. So things like heart failure, if people are building up fluid, we may try to give them a fluid pill or a diuretic, something like Lasix, to help them get rid of the extra fluid. But really, medical therapy is aimed at reducing symptoms and doesn't do anything to treat the root cause, which would be the narrowed aortic valve. The standard of care for decades has been open surgical aortic valve replacement. This is a great therapy. It works really well for a lot of patients, but it is a fairly large surgery and it is quite invasive. This involves a surgeon making an incision, usually down the middle of your chest. They open up the sternum and spread the ribs to directly visualize the heart. A surgeon will cut the valve out and then sew a new valve in its place. Again, it works great for many patients. Oftentimes, this is the best treatment for some of our patients, but it does take a fair bit of time to recover. And especially for patients that may be a little bit older, maybe they have some other medical problems like diabetes, high blood pressure, some arthritic problems that may make it harder to rehabilitate after undergoing open heart surgery. For our patients that are a little bit more frail, open heart surgery would be challenging to recover from, and it probably would take several months for them to feel back to normal again. And so it's great that we now have this other technology, or TAVR, which is a minimally invasive catheter-based treatment to replace the aortic valve. So we'll talk a little bit more in detail about that procedure. You know, what are the benefits? What are the pros and cons of this TAVR, which is minimally invasive, versus the traditional open heart surgical replacement? Well, the most noticeable benefit, I think, to patients is that there's a shorter recovery time. We'll talk a little more in detail about how the TAVR procedure works, but basically you have a couple catheters that are put in through the groin arteries, and the main recovery is just having those heal. So oftentimes patients are back on their feet later that evening. Certainly they are the next day. They make it out of the hospital in a few days, and by 1 week's time, people are back on their feet doing the things that they want to do. And that's pretty much it as far as recovering from that TAVR procedure. Again, I've already kind of mentioned, you know, for open heart surgery, someone who's in really good condition would probably take a good month before they feel back to normal again. But someone who's a little bit deconditioned, maybe has some arthritis, can't get around as easily, is a little bit more weak to start with, that person's going to take probably 3 months to get back on their feet. So without a doubt, the biggest benefit to our patients with TAVR is a shorter recovery time. There's also less life-threatening bleeding with TAVR. There's less risk of having irregular heart rhythms after surgery, like atrial fibrillation. I'm sure you guys have seen ads for atrial fibrillation on TV, and basically it's an abnormal rhythm where the top half of the heart is not pumping appropriately. And this can make people feel unwell. So with TAVR, the risk of developing that is less compared with open heart surgery. Also with TAVR, there's less risk of kidney injury. And part of this is probably because you don't need to be on the heart-lung machine for TAVR. This is done on a beating heart, whereas with open surgical replacement, they have to arrest the heart, put you on a heart-lung machine, and some of that can increase the risk for kidney injury. Also with TAVR, there's a lower risk of stroke. Some of this also relates to not needing to be on the heart-lung machine. You know, that can increase the risk for stroke with open surgery, but this is reduced with TAVR. Now, these are all great, but there are two areas where TAVR is slightly inferior to surgical aortic valve replacement. And one of those is there's a slightly increased need or increased risk for needing a permanent pacemaker with TAVR. And the reason that is because with surgery, the surgeon cuts out the diseased valve and they sew a new valve in its place, and it just sits there. With TAVR, we don't cut out the old valve. The new valve actually goes through your old valve, and then it pushes the old valve to the side. And because it's pushing the old valve to the side, it can put some pressure on different areas of the heart. And I'm not sure, because I think I'm small, how well this will project, but this is a model of the heart, and this is one of the 3 devices available on the market that shows how this works. And you can see that here's the aortic valve that you're born with, and this new valve goes through that, and then this particular device, this balloon, inflates the new valve and pushes the old valve aside. But what can happen is that because this pushes it aside, part of the electrical wiring of the heart runs very close to this. And in particular, there's a little area called the AV node, which connects the A atria to the V ventricles. And so because this device can push on that AV node, sometimes it causes dysfunction where the top half won't talk to the bottom half. And so that's when people end up needing a pacemaker, is when this type of problem occurs. With surgery, that's not an issue as much because there's not as much force pushing on this, and also because they cut out the old valve. But with surgery, the risk of that happening is about 3% needing a pacemaker. With TAVR, it's about 5 to 10%. And I think as we continue to refine our implantation techniques, that rate is going lower and lower. So I do think that as this technology becomes refined and implantation techniques become better, that rate will drop lower and lower and get closer to the 3 to 5% range for surgery. So I think that even though this is more of a risk with TAVR, that all the benefits with TAVR far outweigh that risk. One other area that TAVR can be slightly inferior to surgical aortic valve replacement is that there can be an increase for paravalvular leak. What does that mean? You know, again, if I show you this model, this new valve kind of pushes the old valve to the side. And so you can have leak of blood around this new valve and in between the old valve down back into the ventricle. Now, if that's mild, it doesn't really cause people problems, but if that's moderate or worse, then it can cause some residual symptoms of shortness of breath, and people may not feel very well. Again, as technology has progressed, there's now 3 iterations of this valve. One of the other valves on the market has 3 new iterations, and the other one has 2. So as valve technology improves, we've seen decreasing rates of paravalvular leak. So I think both of these issues are actually becoming a little bit of non-issues as the technology progresses and as we become better at implanting these valves. So overall, if you look at this slide, I think that we'd all agree that TAVR has a lot more advantages versus disadvantages compared to surgery or open aortic valve replacement. And overall, if you're weighing the risks and benefits, I think there's a strong argument that TAVR wins out on a lot of these things. So just to show you the 3 devices that are currently available on the market, this was the first one to market. This is the SAPIEN valve, and it's balloon expandable. And there's been 3 iterations, and actually even a 4th that's not on the slide. That just came out this year, and that's called the SAPIEN Ultra. This basically uses the heart lining called pericardium from a cow that they sew into this valve. Here's another one of the available devices. This is the core valve, which is now called Evolute. This is made from a porcine or pig pericardium, which they again laser cut and then sew into this metal valve frame. And there's been 3 versions of this, more recently the Evolute Pro, which has decreased paravalvular leak. And then the last available valve on the market right now is the Lotus Edge. This one's made from cow or bovine pericardium and has a slightly different mechanism for how it deploys. But these are the 3 available devices that we have to replace the aortic valve at the current time. Again, like I mentioned, this is a beating heart procedure. You do not need to be on the heart-lung machine. Typically, we try to do this through groin access. We access the large arteries in the groin or the femoral arteries to be able to go up with the valve catheter and replace it. If those arteries are too diseased, we may use the artery in the shoulder, or sometimes even go through the carotid artery if the femoral arteries are too diseased. So it's very seldom that we actually have to open the chest, almost never, to be able to deliver these TAVR valves. Again, the typical length of stay is about 1 to 2 days in the hospital. So these are 2 pictures that show 2 of the devices and how they sit in the heart. I showed you that little model for the balloon expandable system here. So you can see the catheter coming up the aorta here from the legs. We come around and cross backwards through the valve that God gave you, and then we put the new valve in there and expand it and push that valve to the side. So that's how this system here works. On this side, this is the self-expanding Evolute Pro, and this one is similarly crossed backwards through the valve, but then this valve kind of gets unsheathed. It's kind of collapsed in a capsule, and then we unsheath it like this, and it opens up. And so that's what you see here is starting to become unsheathed, and as this capsule pulls back, the whole valve will fully deploy. So these are 2 out of the 3 valves that we currently use, and kind of show you a little bit about how they kind of sit in the heart. So if you're found to have aortic stenosis and your doctor sends you to a cardiologist and tells you that you need to be evaluated for TAVR, what can you expect? There's a number of tests that you'll need to do. Usually the aortic stenosis is found by way of a transthoracic echocardiogram or a TTE. This is an ultrasound, just sound waves that they put some gel on your chest and take pictures of the heart. And this lets us get a really good look at how well the heart is squeezing, and lets us look at the valves. And this is how we determine if you have significant aortic stenosis or not. If you are found to have severe aortic stenosis and you are symptomatic, with shortness of breath or fatigue, the things that we discussed earlier, we'll recommend a cardiac catheterization. And the purpose of this is to look at the arteries that feed the heart. Do you have any blockages that may also need to be addressed or may increase the risk of trying to replace your aortic valve? One of the critical pieces of this evaluation is a specialized CAT scan or CT scan that scans from the chin to the pelvis. And what this does is a number of things. One allows us to get a really good look at your valve to see how much calcium buildup there is and to determine if we have a valve that's the right size to fit the valve that you have. And with the 3 devices that we have, it's very seldom that we don't have a valve that fits people just right. We also need to send you to a cardiothoracic surgeon to evaluate your options for open heart surgery to see if maybe that's a better option for you, and also to assess your surgical risk. This really plays into what we think will be the best balance in terms of risks and benefits. If you're really, really high risk for open heart surgery, then we're really going to be trying to pursue the TAVR more. If you're low risk, then I think both options are on the table, and we think about some of the other factors to determine which treatment is best for you. To help determine your surgical risk, you may be sent for pulmonary function testing to see how good your lung function is. And you may also be sent for a carotid ultrasound to see if you have any evidence of plaque buildup in the carotid arteries, which are the main arteries that feed blood to the brain. Both of these things can alter your risk for open heart surgery. So that kind of plays into the risk calculation to see which therapy may fit you better. The most important part of all of this evaluation is the multidisciplinary heart team. Dr. Posenau will talk a little bit about why this is so important, but just to introduce you to the idea of the heart team, this is really a team of multiple healthcare practitioners that work together to make sure that we're covering all of the details and that we decide on the best treatment for each of our patients. This is typically comprised of an interventional cardiologist like myself and Dr. Posenau, a cardiothoracic surgeon who we work hand in hand with for these procedures. This can include our valve clinic coordinators. Sometimes the cath lab or OR staff are there. The anesthesiologist may be there to help discuss what the best approach for anesthesia will be for the case. And we often will include our imaging specialists and sometimes even the referring cardiologist to help decide on the appropriate treatment plan. So this is really key to what we do. We present each case, we go through all of the data, the CT scan, the heart cath, the echocardiogram. We discuss all of the other factors in terms of what other medical problems the patient may have, what their risk may be. And collectively as a group, we decide, okay, for this patient, open heart surgery is going to be the best thing that's going to be the best result with the least amount of risk. Or we may decide, no, for this patient, TAVR is really going to be the best option for them to get the best outcome with the lowest amount of risk. So this is a really crucial part of our program. Here at VCS, we have a number of operators that have helped establish programs across the Richmond area. And we have a program that we do out of Henrico Doctors Hospital, one out at Chippenham, and the one at St. Mary's. My main practice is based out of St. Mary's, and I had a unique opportunity to help establish this heart team at St. Mary's. And since we started this past fall, it's been really fantastic. It's been a collaborative effort. We all work together. And I think most importantly, we've seen an improvement in patient outcomes. I kind of came to that program this past summer, and in speaking with some of the people who were there previously, they've all noted that it seems that the outcomes we had after these procedures has improved. And that's really the goal of this, is that we discuss everyone's case, we all think critically about it, and not only do we learn from each other, but I think it improves the outcomes for our patients. So it's been a really great thing, and I'm glad that we've been able to contribute to this at each of our programs. So what can you expect? If you get signed up for TAVR and we decide that this is the best treatment for you, what can you expect? So a typical hospital course, you'll come into the hospital on the day of your procedure. We'll take you to the preoperative holding area. Then we'll bring you back to the hybrid operating room. The procedure usually takes, maybe 45 minutes up to an hour, sometimes an hour and a half. And we do this either under general anesthesia, where an anesthesiologist completely puts you to sleep and then they wake you up afterwards. Or oftentimes we can actually do this under conscious sedation. This is such a minimally invasive procedure that many times we can just give you a sedative and a pain medication and you'll kind of feel sleepy. Some people drift off to sleep. Some people are just kind of out of it, but we don't have to put you completely asleep. And the advantage to that is we don't have to put you on a breathing machine. For open heart surgery, not only do they put you on the heart-lung machine, but you're on a ventilator to support your breathing because they have to sedate you so deeply for the procedure. But with TAVR, it's so minimally invasive that we can just make you feel comfortable and you don't have to be on a breathing machine. And this really helps people recover even faster because they don't have the after effects of anesthesia. So after you get this procedure done, after 6 hours or so, you can get up out of bed, walk around the hospital. The next day, we monitor you on heart monitoring to check your rhythm, to make sure you're not developing any evidence of the problem of heart block with the top not talking to the bottom. We'll have you walk around. Physical therapy will assess you and see how you're doing. And some people actually go home on the next day if they're doing really well. Without going into details, I just had I think he was 91-year-old gentleman that we treated last week, and he was doing so great the next day that we let him go home the next day, and he's doing fantastic. So this has really been a remarkable transformation in how we treat aortic stenosis. For some patients, those who might be a little more frail, we may keep them a second night in the hospital. We'll often do another ultrasound of the heart or an echo before they go home, and then you go home. Again, people are often back to doing whatever they want within 5 to 7 days. And with their aortic valve replaced, their shortness of breath is gone, their fatigue is gone, and they feel fantastic. So this is really a remarkable technology that we're now able to offer to our patients. It lets them get back to doing what they want much, much quicker. In terms of follow-up care after undergoing this procedure, we do keep people on blood thinners for a short period of time. That's not the more heavy-duty ones like Coumadin or Xarelto or Eliquis. It's things like aspirin and Plavix. And then typically we'll keep people on aspirin indefinitely for a lifetime. That just helps the valve function well and prevents it from degenerating. We do ask patients to take antibiotics before seeing the dentist for about 6 months. That's because when you see the dentist, you can get small amounts of bacteria that get released into the bloodstream. We don't want that to stick to that brand new valve that you have, so we have you take antibiotics before seeing the dentist. After 6 months, this healing process has really occurred, and so technically you don't need to be on antibiotics. If we're worried, we may keep you on it for longer, but by guidelines, you only need it for 6 months. And then we'll repeat an echo at 1 month and often at 1 year, and we'll see you in the office to make sure you're doing well. And one of the most rewarding parts of what we do is when I see someone back after one of these procedures and just a month later they're telling me about how great they feel, how different their life is, able to play with their grandkids, do gardening, exercise. It's just one of the most rewarding things to see how well patients can do after this procedure. So I'll stop there. Hopefully I haven't used up too much time, but we'll have time for questions at the end. I'm going to turn it over to Dr. Posenau to talk a little bit about the options we have for mitral valve disease. And specifically, he's going to talk about the MitraClip, which is currently the only commercially approved device to treat a leaky mitral valve. So thanks very much. We'll get back together at the end for some questions. I'll turn it over to Dr. Posenau.
Great. Thank you, Matt. So I'm Trevor Posenau. I'm one of the structural and interventional cardiologists here at Virginia Cardiovascular Specialists. And I'm going to be talking about mitral valve regurgitation and specifically transcatheter mitral valve repair, or MitraClip. So as Dr. Chung previously mentioned, mitral valve regurgitation is one of the common valvular issues that we see in our practice. Mitral valve regurgitation occurs when the mitral valve, which separates the heart's left atrium from the left ventricle, becomes leaky. And as a result, when the heart pumps, some of the blood flows backwards across the valve rather than out of the heart. That results in leakiness or mitral regurgitation. Mitral regurgitation can occur for several reasons. There is primary or degenerative mitral regurgitation, which we consider to be a problem of the valve. With primary regurgitation, the actual anatomy of the mitral valve becomes abnormal in such a way that when the valve closes, there is excessive tissue mobility or prolapse, and as a result, the valve does not seal tightly, but instead can seal with a leak, and a lot of blood can flow backwards across the valve. And this is, again, degenerative or primary mitral regurgitation. There is also a different type of mitral regurgitation, which we see more commonly in patients with heart failure. And this type of mitral regurgitation we call secondary or functional mitral regurgitation. And it's a problem not so much of the valve, but of the heart's muscle itself. In patients who have heart failure with resulting weakened heart muscles, the heart's main pumping chamber, called the left ventricle, can become dilated or remodeled in such a way that it actually pulls the leaflets of the mitral valve apart. So rather than sealing tightly, they get pulled apart by the connections to the heart's ventricle. And this results in severe leakiness as well, but from a different mechanism. We call this secondary or functional mitral regurgitation. Mitral regurgitation can occur on a spectrum from trivial to mild, moderate, or severe. And it's typically not until the leakiness becomes severe that we begin to think about interventions and therapies for patients. So the symptoms of severe mitral regurgitation can mimic a lot of the symptoms we see with other valvular heart disease, such as aortic stenosis. And specifically, we often see patients present with heart failure symptoms, which can include fatigue or inability to exercise or even perform routine daily activities, shortness of breath, swollen feet or ankles is another side effect of heart failure, or potentially rapid heart rate with associated atrial fibrillation as a result of mitral regurgitation. So when patients become symptomatic with their mitral regurgitation, they often come to the attention of the cardiologist. And we have several potential therapeutic options for patients with severe symptomatic mitral regurgitation. Virtually every patient with mitral regurgitation that's severe will receive some form of medical therapy to try to improve their symptoms. Often this is with a diuretic or a water pill to help the patient control their fluid status so that they're not accumulating too much fluid in the body. For patients who have heart failure or hypertension, we often end up on blood pressure medications or heart failure medications such as ACE inhibitors or beta blockers, which can help reduce their heart failure symptoms, and in some cases can help control the mitral regurgitation with medical therapy alone. For patients who have abnormal heart rhythms, specifically a problem called a left bundle branch block, they may be candidates for electrophysiologic EP intervention called a cardiac resynchronization. However, if patients go through the full spectrum of medical therapy and continue to have symptomatic mitral regurgitation, then it's oftentimes the point where we begin to think about mitral valve interventions. Now, for patients who have primary or degenerative mitral valve regurgitation, the standard of care has been open surgical repair or replacement of the valve. And this is still the standard of care for patients who are low or intermediate risk for open heart surgery. So for patients who are relatively young without few other medical issues, they often go for surgical repair of their mitral valve regurgitation if they have a primary degenerative process. However, for patients who are high risk for open heart surgery, or for patients who have heart failure with weakened heart muscles who have secondary mitral regurgitation, we now have a minimally invasive transcatheter option called transcatheter mitral valve repair or MitraClip, which is something we can do through our practice at VCS. So what are the advantages of MitraClip versus open surgical repair? Many of the advantages are similar to those that we see with other transcatheter therapies such as TAVR. The MitraClip offers a shorter recovery time, primarily because it's a catheter-based procedure done through a small puncture in the groin rather than having open heart surgery with a sternotomy. So the recovery time from a MitraClip can be measured in days rather than weeks. For patients who have heart failure and secondary mitral regurgitation who undergo MitraClip, we've seen that these patients have less trips to the hospital for heart failure, less hospitalizations. There's actually a reduction in overall mortality after MitraClip in patients who have heart failure who receive a MitraClip procedure. And there's an improved quality of life. Patients are able to do more of the things that they'd like to do after a MitraClip. For patients who have degenerative or primary mitral regurgitation, and again, that's a process where the valve itself has deteriorated and become leaky. When we compare MitraClip to the gold standard of open surgical repair, we know that the MitraClip is often less effective in getting a complete reduction or elimination of the mitral regurgitation. We can oftentimes reduce severe mitral regurgitation to mild or trace mitral regurgitation, but even with this reduction, patients can still experience a significant improvement in their quality of life without having to endure the risk and the recovery of open heart surgery. So if you're a patient who has severe mitral regurgitation who's high risk for open heart surgery, or if you're a patient who has heart failure with moderate to severe mitral regurgitation on optimal medical therapy, then it may be appropriate to be considered for a MitraClip. To determine if you're an appropriate patient for a MitraClip procedure, there is an evaluation process that we perform through our clinic and through consultation with our cardiac surgery colleagues. The most frequent first step in evaluating mitral regurgitation, besides a clinical appointment and physical examination, would be a transthoracic echocardiogram, which is a non-invasive ultrasound of the heart that's done externally through the chest wall, and it allows us to see heart size, heart function, and also evaluate how significant we think the mitral valve regurgitation is. If we think that your mitral valve regurgitation is severe and would like to pursue the mitral clip process, then there are several other additional tests that we will send patients for that are typically performed in the outpatient setting, but we send patients to the hospital for the day for the testing, and they are often discharged later that day. Those tests can include the transesophageal echocardiogram, which is really the most important test in evaluating a patient to determine if they're the right patient for a MitraClip. Transesophageal echocardiogram is a procedure done under conscious sedation, typically in a cath lab setting, where we actually put the ultrasound probe down the patient's esophagus so that the probe sits right next to the left atrium of the heart, basically right next to the heart. And this allows us to get really high quality pictures of the valve to determine how leaky it is, to measure the size of the valve leaflets, the area of the valve, the gradient across the valve. And this is really the procedure that gives us the most sense of how successful we think we will be with the MitraClip procedure. Also, for patients who do go on to get MitraClip, the transesophageal echocardiogram is really what guides us during the procedure. So getting a really high quality TEE up front is very important. For many patients who are being evaluated for MitraClip, they're also sent for a cardiac catheterization. This is a procedure where we evaluate the pressures in the heart and also evaluate for any blockages in the heart arteries that could be contributing to their symptoms of shortness of breath or heart failure. And every patient that we're considering for MitraClip is also sent to see our cardiac surgery colleagues. And the reason we do this is we evaluate every patient in a multidisciplinary fashion with our heart team approach. So why the heart team? The heart team is a multidisciplinary discussion of each patient's case. And we have this discussion after both the interventional cardiologist and the surgeon have met the patient, and sometimes also a heart failure specialist if the patient has heart failure and secondary mitral regurgitation. But we all get together and we have all the patient's information in hand, imaging, cath data, and we've all met the patient, and we discuss the case in detail. We look at the anatomy, we talk about procedural risk to try to get a sense of if we agree that patient's low or intermediate or high risk for surgery. And in going through this conversation, we're able to identify the most appropriate therapy for each patient, and that decision is made by a team of specialists, the surgeon, cardiologist, rather than one individual. And I think that's a very powerful tool that we can use to make sure we get the right therapy for each patient, and we can plan the procedure in detail to know exactly what we're getting into before we start the procedure. So after the heart team is met, we'll typically reach out to the patient and let them know what our recommendation would be as far as how to address their mitral valve regurgitation, and if agreeable, then we'll schedule them for their procedure, whether that be a surgery or our MitraClip. So if we do recommend the MitraClip procedure, which again is for patients who are high risk for surgery or for patients who have heart failure with secondary mitral regurgitation, we will go on to recommend the MitraClip. And this is a schematic of what the MitraClip device looks like. It's a fairly large device with a catheter system with lots of cables and control knobs that allow us to steer the MitraClip device. But the working end of the device is this clip here, which is the MitraClip itself. It's sort of like a staple with little grippers, and these grippers are able to cinch on to the two leaflets of the mitral valve. And once the grippers have grabbed the mitral valve, we can bring the clip together to sort of cinch the leaflets together and reduce the leakiness. So this is a beating heart procedure. There's no heart bypass required for MitraClip placement. And the procedure itself is done in our hybrid operating room under general anesthesia. Once anesthesia has been obtained, we'll place the transesophageal echo probe down the esophagus, as I had mentioned, to help guide the procedure with TE imaging. And then we'll obtain access to the right femoral vein down in the groin. And through this access, we'll ultimately insert our MitraClip catheter, which is this device. And we'll take this catheter up to the heart, and we'll actually perform what's called a transeptal puncture, where we cross over from the right atrium of the heart to the left atrium of the heart. And by entering into the left atrium, which is this chamber here, we're directly above the mitral valve. And once we've gained access to the mitral valve, we will bring up our MitraClip device, and with careful positioning and steering, we will then align this MitraClip so that we can drop it just underneath the valve in a very linear fashion so that it lines up exactly with the leaflets. And then we will bring the clip backwards, and using the gripper arms, we'll actually be able to secure the two mitral valve leaflets within the clip and cinch the leaflets back together. So for patients who have a leaky valve that's prolapsing, we're able to grab both leaflets and grab them and bring them back together so that the valve closes more completely, and we're able to substantially reduce the leak. Now, for some patients, the valve can be improved with just one clip, but some patients need 2 or even 3 clips lined up side by side in order to significantly impact the leakiness of the mitral valve. And for most mitral valve procedures, we're able to reduce the leakiness from a severe leak down to a mild or trivial leak, and that is often enough to make patients feel substantially better. So this is what you should expect if you're coming in for a MitraClip procedure. So hospital day 0, you would arrive as an outpatient typically, and come to the pre-op holding area. Once you've entered the hybrid operating room, the MitraClip procedure will begin, and it typically takes about 1 to 2 hours under general anesthesia. And then after the procedure, the sheath is basically removed immediately, and patients are able to ambulate within about 4 hours of completing the MitraClip. So you'd stay in the hospital at least for 1 overnight period. You'd be monitored on telemetry. The next day, you would be asked to walk the halls, make sure you feel well. Physical therapy may evaluate you. It's routine to get a transthoracic echocardiogram on the first postoperative day to further document the reduction in mitral regurgitation. And then many patients are able to leave the hospital on post-op day 1 after a MitraClip, which is really fantastic. So follow-up care after the MitraClip, patients are typically on a blood thinner for a short period of time. Most commonly, that's aspirin and Plavix. And the Plavix is usually for a short duration. The aspirin may be sort of an indefinite therapy, just a baby aspirin. Patients are typically given antibiotics when they see a dentist for prophylaxis against infection of the MitraClip device. Patients have to come back for a repeat echo in 1 month after MitraClip, and also 1 year after MitraClip. And then we see them back in our clinic as well to talk to them and see how they're feeling after the MitraClip procedure. I think that concludes our prepared materials about TAVR and MitraClip, and we're now free to answer any of your questions. We really appreciate your time.
So we had a couple questions come in through the portal here. Before we kind of jump into those, one thing I did want to mention is that, we didn't really talk about, obviously this is a strange time we're all dealing with COVID, and there's a very understandable amount of anxiety of patients even coming into the office and coming into the hospital to get testing done. I think it's a legitimate concern, but I think that we've done a really fantastic job at our various sites around Richmond at being selective about who can come into the hospital. There's been very stringent screening procedures to make sure that people who have symptoms that are concerning for possible COVID aren't allowed to come into the hospital. And the hospitals have really done a great job with infection control, people wearing masks, and trying to really minimize people's interactions. You know, for some of these procedures, you do need testing that's done at our personal offices, and we are really limiting foot traffic in our offices and have been using very strict protocols to wipe down all surfaces and things like this. And so, you know, the bottom line is that for these conditions that we've talked about today, if you're having problems with that, there's a lot of risk to just kind of sitting and waiting it out. You know, there's actually literature and research showing right now that for other cardiac conditions, like people who are having heart attacks or, you know, maybe have a weakened heart muscle, that people are staying at home and waiting until it's too late. You know, just even speaking candidly with some of our colleagues who work in emergency medicine or some of the EMTs, they're often finding that when they get out to the field to see people who have called 911, that there's more of these patients that they can't resuscitate before they even bring them into the hospital because people are waiting too long. So I just want to mention that, you know, I think we can get the testing that's necessary for these tests done and keep you safe, and that we certainly want to make sure that if you're having any of these issues, that we try to get them addressed sooner than later, because people can run into issues if they wait too long. So with that, I think we have a couple of questions here. I'll take the first one. One of the questions from the portal was, after TAVR, what are risks to the new valve or other structures from a follow-up ablation procedure? So it's a great question. And the answer is not many at all. You know, if you're talking about ablations for irregular heart rhythms like atrial fibrillation or atrial flutter, or maybe if you have ventricular arrhythmias that need to be ablated, these don't really affect that new valve. You know, if you were going to go for these procedures in the short term after getting a TAVR, we would be extra cautious about your risk for introducing bacteria into the bloodstream during those ablation procedures. But other than that, these ablations can't really hurt that heart valve because typically they're far enough away from the valve that they're not going to damage it. So really the main concern would be just making sure that things stay sterile and that we don't introduce any bacteria into the bloodstream.
All right. So another question we received is, if I've already had open heart surgery, such as a CABG or bypass procedure, will I have to have my valve replacement with a TAVR? For patients who have already had one open heart surgery with a sternotomy, if they go on to develop valve issues such as aortic stenosis or mitral regurgitation, they do typically face some higher risk for a repeat surgery because there's often a significant amount of scar tissue and some difficulty to go back through the sternum that's already been opened once with a previous surgery. So for patients who have already had one open heart surgery with a sternotomy that have severe aortic stenosis, we oftentimes do look to doing a TAVR procedure if they're a candidate for TAVR. If we think that's the best way to replace their aortic valve, then definitely we would probably prefer the TAVR for most patients.
Yeah, I'll just add to that it's not imperative that the valve replacement is done that way, but for most patients that have already had their chest cut open one time, oftentimes that would be the preferred strategy because, again, it's just so much less invasive and it's going to be easier to recover from. And like Dr. Posenau said, the risks of redo surgery are higher than if it's the first time around. So oftentimes it does push us towards trying to do TAVR if possible. Another question that we had was, if you already have AFib or atrial fibrillation, when you have a TAVR, are you likely to need a pacemaker? I would say that having AFib at the time of TAVR doesn't really change your risk for a pacemaker all that much. There's been a lot of research looking at risk factors that increase the need for a pacemaker after TAVR, and atrial fibrillation hasn't really been identified as a risk factor that increases the risk. Really, the things that we think about that may increase your risk of needing a pacemaker after TAVR have to do with pre-existing conduction disease or evidence on an EKG where they put all the leads on your chest and you get the little heart tracing, evidence that you've already got some slowing of the electricity passing through the electrical wiring of the heart. So things like if you've heard of a bundle branch block, if you have a right bundle branch block, or if there's already evidence of what we call a first degree heart block, where the electricity is already traveling slowly from the top to the bottom, those have been identified as some risk factors for increasing the potential need for a pacemaker after TAVR. But I will say that even in patients that have very advanced conducting system disease, even if they have a first degree heart block, even if they have a right bundle branch block, or even more high degree levels of block, we've become refined enough in our approach and our valve choice and how we put it in that even those patients can get TAVR and avoid needing a pacemaker.
Right, another question. A patient already has, or a patient has 3 leaky valves. How common is that, and what will need to be done? So we see many patients who have valvular heart disease affecting multiple valves. Some patients, they have multiple severe valvular heart problems. Some patients have a primary or more severe problem with one valve and more mild problems with their other heart valves. And so I think it really depends on each individual patient. For patients who have problems with more than one valve, we would identify that on echocardiogram, same as any other patient, and we would have to take each valve and the severity of each valve problem into consideration when identifying the best strategy for how to treat the patient. But for many patients with multiple valve issues, there's often a dominant valve problem that can be addressed first, but it really depends case by case.
And that's one of the beauties of the heart team, is that these are some of the most challenging cases that we discuss are people who have multivalvular disease, 1, 2, 3, 4 valves disease. But the beauty of the heart team is that we all look at the data. We try to discuss, which valve is causing the most problem. Sometimes if you fix one valve, some of the other valves can get better. And so by discussing this as a team, we can really decide what needs to be treated first and what other potential treatment options may be down the road if needed. And we have a couple more questions here, and I want to be respectful of your guys' time, so we'll keep moving along. Another question is, 8 years ago, I had open heart surgery for aortic valve replacement with a bovine or cow valve, and now have a pacemaker. When this valve needs to be replaced, would I be a candidate for TAVR? The question is yes, but we would have to go through the appropriate evaluation that we've outlined. Most importantly, we would need to get that TAVR CT, which is that CAT scan from chin to pelvis, because that will show us how that surgical valve is sitting in the chest. It'll show us where do your coronaries take off above that, and what are the risks if we try to put a new valve inside of that valve. So yes, absolutely, for someone like that would be a candidate for TAVR, but we'd have to go through the full evaluation, and the CT scan would be critical in deciding if that person would be a good candidate for a so-called valve-in-valve procedure. Some more questions here. Let's see. You want to do this one? So here's a question with Dr. Posenau answer. What is the future prognosis after TAVR? Will the new valve last a lifetime? That's a great question.
So for many patients who get a TAVR for severe aortic stenosis, we're able to substantially improve their symptoms and also their long-term prognosis. The prognosis for patients who have severe symptomatic aortic stenosis who do not get their valve replaced is very poor. Before there was the ability to do open heart surgery, these patients, this was 40 or 50 years ago, patients that had severe aortic stenosis would oftentimes not make it more than a couple years. But with the ability to replace someone's aortic valve, we can extend life by potentially decades for some patients, depending on how old they are and their underlying health conditions. As far as the duration or the durability of the TAVR valve, right now we think that they're just as durable as surgical bioprosthetic valves, which we typically quote a durability of about 10 years or so, but it can be dependent on how old the patient is. Younger patients typically tend to wear down their valves a little bit more quickly than older patients, but in general, we think that most TAVR valves should be okay for at least 10 years. But if a patient has one bioprosthetic valve and that becomes deteriorated after time, then we do have the option of potentially doing a second valve replacement when that first valve becomes deteriorated, and whether that be with surgery or a second transcatheter valve inside the first one, or we call a valve-in-valve procedure. But typically the prognosis after a TAVR, if we can take a patient with severe aortic stenosis and give them a new valve, the prognosis is great.
Another question was about the types of valves available on the market. So yes, there's 3 different valves available. One is that balloon expandable Edwards Sapien valve. One is the Medtronic Evolute Pro self-expanding valve. And then the third is the Boston Scientific Lotus Edge, which they call mechanically expanded, which is a little bit different than self-expanding. But in terms of the valves that we use in our practice, the first valve to market was the Edwards Sapien balloon expandable valve. And that is one that we use at all of our sites where we do TAVR. We also use the Medtronic Evolute Pro self-expanding valve. And one valve is often better suited to one person's anatomy than the other. And so the nice thing about having access to both of these 2 valves is that we can really tailor which valve we use to optimize the outcome. To reduce the risk of pacemaker, to make sure there's not leak, to make sure that there's minimal obstruction through that valve. So those are the 2 main valves that we currently use in BCS for our TAVR programs. Again, we do those currently at Henrico Doctors Hospital, at St. Mary's, and at Chippenham. The third valve, the Lotus Edge, was on the market. It got pulled to revamp it a little bit. It just recently came back to market. I know that at St. Mary's program, where I do a lot of my work, we evaluated that valve. We decided that it wasn't going to be common enough to use it to have it make sense to use that valve right now. I think Dr. Posenau, doing most of his work over at Henrico Doctors, they also kind of had the same determination that that's not a valve that we're going to use very much. But by and large, the majority of TAVR valves being used in the US and even across the world right now would be the balloon expandable Sapien and the Evolute Pro self-expanding valve. And so we use both of those valves in our practice. This one here.
Sure. Another question. The mitral valve, can it be affected by stenosis? And if so, can a mitral clip help with mitral stenosis? So the answer to this question is actually no. The mitral clip is only designed for mitral regurgitation. Mitral stenosis, which is a thickening or a narrowing of the mitral valve orifice resulting in increased gradients across the mitral valve, can cause symptoms that are similar to mitral regurgitation, but we have to treat mitral stenosis in a different way. There are potentially medical options for mitral stenosis, such as beta blockers to help slow heart rates, but for patients who have severe symptomatic mitral stenosis, again, mitral clip is not an option. Those patients either have to get a balloon valvuloplasty procedure if they have, say, rheumatic mitral stenosis, or for patients who have more calcific mitral stenosis, which is developed over many decades of life, some of those patients have to get open mitral valve replacement surgery instead.
Another question we have is, what can be done for a patient that has problems with both valves, TAVR and the clip? And the answer is yes, both procedures can be done. Oftentimes, people that have both a narrowed aortic valve and a leaky mitral valve, some of that is partially because the blood flow is so obstructed coming out of the aortic valve that blood takes the path of least resistance. So, on this model, this is the aortic valve, and here's the mitral valve with the clip on it. But if you've got a narrowed aortic valve, it's going to be hard for the blood to get ejected from this chamber out the aorta. And so it's going to take the path of least resistance. It's going to go backwards through the mitral valve. So sometimes people who have a leaky mitral valve in conjunction with a tight or narrowed aortic valve, if you fix the aortic valve with TAVR or aortic valve replacement, the mitral valve won't leak as much. And over time, as the ventricle heals, because it's now got that weight lifted off of it, a lot of times the mitral valve will function better and it won't be so leaky. But for some patients, that's not the case. And in fact, there was a nice gentleman that I had that had both problems, but after discussion in the heart team meeting, we did TAVR to fix his aortic valve. Did better, but still had some symptoms, and it was clear that the mitral valve was still quite leaky. and something was going to need to be done about it. So this gentleman, about 2 weeks after his TAVR procedure, came back, and I put a clip, this little glorified clothespin, the white thing right there, I put a clip on his mitral valve. And after that, his symptoms got much better, and he's now back to golfing, I think 9 holes. I don't know if he's up to 18 holes yet. I think he was last time I saw him. But, he's back doing the things he enjoys. So yes, sometimes patients need both procedures, but oftentimes if it's aortic stenosis and mitral regurgitation, the 2 conditions that we talked about, we'll treat the aortic stenosis first, wait and see if the mitral regurgitation gets better. And if it doesn't, then we can always, if they have a good anatomy for it, put a clip on the valve to treat the leakiness.
So another question, how will mitral repair affect lifespan and quality of life? So certainly for most any patient who has severe symptomatic mitral regurgitation, who gets a mitral valve repair, whether with surgery or with MitraClip, their quality of life should be significantly improved after they've recovered from the procedure, because we've taken that leakiness and reduced it from severe to hopefully mild or trace for most patients. I think the question of lifespan really depends on patient. For patients who have other medical comorbidities or who have heart failure with resultant mitral regurgitation, their expected lifespan will be impacted by their other health conditions, and in comparison to a patient who may just have isolated primary degenerative mitral valve regurgitation who undergoes a mitral valve repair. So I think the impact on lifespan can really just depend on each individual patient's other medical problems. But I think it's safe to say that for any patient who has a successful mitral valve repair procedure, their quality of life should be significantly improved.
There's 2 questions. I think these might be the last 2 we've received so far. They're kind of related. One of them was asking about what the warranty on a TAVR valve is, and the other one asked in a slightly different way, what is the life of a TAVR valve? Like Dr. Posenau said, we think that TAVR valves, based on the research we have so far, last at least as long as surgical biological valves. So those would be bovine or porcine, cow or pig valves. According to the data we have from many, many years of surgical aortic valve replacement, like Dr. Posenau said, those can last on average about 10 years, sometimes less, sometimes more. Some people can get 15, 20 years out of a bioprosthetic or biological valve. And so far, the TAVR valves, the first one was done back in 2002, so we've got about 18 years of data. So far, those seem to have the same longevity as the biological surgical valves that are put in. And getting to the point about what do you do when it wears out, like Dr. Posenau said, for some patients, even if you have, let's say, 1 surgical valve, or if you have 1 TAVR valve, depending on how your anatomy is built, you can actually put a second TAVR valve in that first TAVR valve. And what the question is, are there any unusual risks with doing valve and valve? And the answer is yes. It can be a slightly riskier procedure, and the main risk that we worry about is obstructing the coronaries. On this model here, here's the aortic valve again, and then can I borrow that pen right there for a second? Here's the aortic valve, and the coronaries, they're not shown in this model, but they actually take off kind of here on one side and here on one side. There's a right coronary and a left coronary, and they split and feed the heart. And for some people, these coronary takeoffs are very close to the plane of the aortic valve. And you can imagine that if you already have 1 valve that sits right here, and you go and put another valve inside it, what's going to happen to these leaflets? Are they going to get plastered up and seal off that coronary? And so that's the main risk when you're talking about valve and valve, is that when you go and put a new valve in, or even for some people with their first valve replacement, we worry about these leaflets kind of folding up and covering the opening to the coronaries. And so for people who have kind of small aortas, there's not much space in there, or if they have coronaries that take off relatively low compared to where their aortic valve lives, they may not be a candidate for valve and valve replacement because we worry about the risk of coronary obstruction. But like I said, this field is always rapidly moving forwards, and there's new techniques being developed. And so for even people who are at high risk for coronary obstruction, there's new procedures developed where you can actually take a tiny wire and pierce through that leaflet electrify the wire so there's a current running through it, and then use it like a bread or cheese slicer to slice that leaflet, so then it then splits the leaflet so that it doesn't occlude the coronary. And this is, something that's been in development just really over the past year, and it's something that we've started to kind of incorporate into our practice here in Richmond. But even for people who have kind of high risk features for obstructing the coronaries with a valve and valve, even for those people, we now have some treatment options to be able to do TAVR. So, there's always new techniques and new technologies being developed to be able to prevent our patients from having to go through open heart surgery. Let's see, I think we're kind of running late on time here. I think we've answered all the questions. Was there one more? What is the?
Please share information on excessive heart rate and had an electrical shock procedure. What kind of evaluation will be needed in the future?
Please share any information on excessive heart rate, had an electrical heart shock procedure. What kind of evaluation will be needed in the future? I guess this is probably someone who had a cardioversion for some irregular heart rhythm.
It's hard.
Go ahead.
I guess based on the description of the question, it's hard to know if there's a valvular heart issue or not. Arrhythmia can be associated with heart rhythm problems, particularly we're talking about mitral regurgitation. There can be an association with atrial fibrillation, which is probably the most common reason for someone to get a cardioversion procedure. So, typically for anyone who has atrial fibrillation, they get a screening echocardiogram, ultrasound of the heart to identify if there's any underlying structural or valvular issues that may be contributing to their electrical problem.
And I think this will probably be our last question here. And thank you guys for all the great questions and interaction. We really appreciate it. These are fantastic questions. But this last question here is, what is the success rate of the TAVR procedure? Good question. Again, with the improved devices, multiple of them with now 3 iterations, and as we've refined our implantation techniques, the success rate is quite high. The research that we have, being able to successfully put in a valve and get a good result is upwards of about 95%. And so this has now gotten down to a science where we can do it safely, we can do it without having leak around the valve, and we can make sure that we sufficiently reduce the obstruction through the valve. And so with the current technologies and implantation techniques, we now can do this procedure with great success in an overwhelming majority of our patients, again, probably about 95+%. So I think, with that, thank you guys all for joining us today. This has been a lot of fun. Both myself and Dr. Posenau would love to talk with you guys more. We'll send out links to some videos on our website that will give you more information about these procedures. It will reiterate a lot of the stuff that we talked about today. There'll be links specifically to each of our kind of individual info pages. So if you have any questions, by all means, call either of our offices, call any of us. Happy to talk anytime. We want to help you guys out. And if we can do anything for you for this kind of stuff or otherwise, please, by all means, reach out to us. We really appreciate it.
Thank you for your time.
Thanks, guys.
Good job.
I think it's still on.
They had a lot of questions.
There you go. Bye.